I'm Angela Hardwick, and I'm one of the fellows here that work with the Movement Disorder Group. I've seen some of y'all before, and I'm going to talk to you today about medications. This presentation was also put together with some of the help from Dr. Ramon Rodriguez, which many of you see in clinic also, but I just want to acknowledge him. So before I can tell you how the medicines work, I kind of have to tell you. All right, so Dr. Factor this morning talked about how the medication, how the dopamine cells in the brain are starting to kind of die. And that's why you start to get the symptoms that you have. So first I'm just going to give you a brief rundown on how it works in the brain. So you have these building blocks, tyrosine, and that's what's at the very top you see coming into the cell. That's used to make L-Dopa. That gets made into dopamine. Then it gets packaged in that little round ball that you see, and that's dopamine into the package. That package then gets dumped out at the end of the cell to talk to the next one. And it talks to the next one by dumping out the dopamine and going to those receptors that kind of look like these things, and it sends the message on through. So when this system isn't working as well as it should, that's why you get the symptoms that you see, the slowness, stiffness, and the tremor. So we try to fix this along the way, and that's how the medications are going to work, and I'll explain. So this is a list of the most common medications that we treat Parkinson's disease with, and a lot of you may see medications that you may be taking on here. The medication names that are in the parentheses, those are the brand names. And so Sinemet, when we say Sinemet, that's the brand name, but some of y'all may call it Carbidopa, Levodopa, because that's what's written on the prescription bottle that you get. So first, let's talk about the first one, the Carbidopa, Levodopa. This is what Dr. Rodriguez calls the gold standard medication. The Rolls Royce is what he's sometimes described it to some patients. It comes in two flavors, regular release, controlled release. Controlled release, sometimes taken at bedtime and kind of slowly over time releases, and the immediate release usually works within 30 minutes to an hour. It's the Levodopa part that's actually doing the work, and the Carbidopa part is helping to relieve your nausea and your vomiting. So Carbidopa, Levodopa, I told you, is also called Sinemet, and that means without vomiting is what it means. So that's the Carbidopa is to stop the vomiting, and the Levodopa is the business end. So what takes us back to this picture. So at the top, you'll see the orange, it says Levodopa, and it's going into the cell there. And that's where that medicine is working. So it gives the Levodopa to that cell, so then it can get packaged back to that little ball to get pushed out to the cell to go meet the ones at the other end that are kind of like the receptors. So when we give you that medicine, that's what it's doing inside your body. So this is, as he says, the best medication for Parkinson's disease. It does help those symptoms of the stiffness, slowness, the tremors that you can have. Some patients think it helps with unsteadiness, but it's not the case for everybody. And one thing that we worry about is that after years and years of using this medication, you can have motor fluctuations and dyskinesias. So those of you who you guys are the 101 classes, some of y'all may not have these problems, but motor fluctuations are wearing off, or if you take your pill and it's suddenly, hey, what happened? I just took it an hour ago and it's not working anymore. Also dyskinesias, which are kind of those writhing movements. It can be the whole body, it can be just an arm, it can just be the head. But it can be many parts put together. So after years of taking this medication, this can occur in some patients. And since we know this can occur, we usually try and use this medication after we've tried some other meds to treat, or when the Parkinson's gets to that state where you just need the medications and we manage those possible side effects. So next, the COMT inhibitors. So the body's great in that it has this cleanup crew, or a garbage crew. So you see how the cell comes down, packages it up, throws the dopamine between the two to go to the binders. Well, if there's leftover, someone has to clean that up. And that's the role of the COMT inhibitors. And so they not only do they work here inside the brain, but they also work in the rest of your body to make sure that medicine that you just took actually gets to the brain. So it's got two spots. It works throughout the body to make sure it gets to the brain, and inside the brain, it's the cleanup committee, okay? To make sure there's no, so if you block the cleanup committee, you can imagine you got more dopamine's available to do its job and get to the receptors. So that's the role of this medication. The most common one that we give out in clinic is Comtan. And so this one works a lot in the rest of the body, making sure it actually gets to where it needs to go. It works along with Levodopa. If you just take it by itself, it doesn't do anything. You got to take it with a Sinemet, with a Carbidopa, Levodopa tablet in order for it to have some benefit. And so its role is to allow the Levodopa to work for longer periods of time, and it makes it maybe sometimes a little bit more stable. Entacapone is another one. It's the same one, sorry, and it does have side effects. It causes your urine may be a little orange. It's not a problem though. You may get a little diarrhea, which if you've got constipation, it's a nice balance to kind of even it out. The only thing is, since you got more dopamine between the two cells there, you can get a little of those wiggly movements, the dyskinesias, but sometimes we can help manage that. And it's useful for the motor fluctuations, the sudden offs, the seeming like the medicine just isn't working as well. So it comes to Stalevo. So Stalevo is a nice medication because it's 3 pills in one. It's not nice. You don't have to keep taking more tablets. It gives you the Carbidopa, the nausea medicine, the Levodopa, the business end, and the COMT inhibitor, which is the cleanup committee. So it extends the life of the pill. You have the benefit of taking fewer tablets, but the side effects are about the same as you'd get with Sinemet. Dopamine agonists. So these are the mimickers. So as you can see, between the two cells, you've got the receptors out there ready to grab the dopamine. We can just give you something there that looks just like dopamine. Your body feels, oh, it's here, the medicine's here, great, but it's a mimicker. So that's that one's role. This is Mirapex, Pramipexole. It's not better than Levodopa, but it is useful in the beginning stages, in the early Parkinson patients. And it may delay the appearance of some of those motor fluctuation things that we talked about in the beginning, and some of the dyskinesias. Some of the side effects, though. So when you take this medication, we frequently may ask you, are you gambling? Are you more addicted to sex? Are you shopping all the time? Are you on the computer all day long? It can cause that as a side effect, unfortunately. When we stop the medication, these two side effects do generally resolve, but it is something that we do check up on. And this medication, unfortunately, is a bit more expensive than Levodopa. Levodopa is a nice medication that's been around for a while, so now it's a little cheaper. And this mimic medicine is a little pricey. So Requip, or Ropinirole, similar. It's another mimicker. The side effects are just the same, and the cost of it is about the same also. Neupro, or Rotigotine. So maybe a few years ago, some of y'all may have been on this, it was a patch, and it was a mimicker also. And it was very nice, because you stick the patch on, it slowly over the course of the day releases its medication. People didn't say it had that peak and valley feeling. Unfortunately, the medication was crystallizing on the patch, and so it had to get taken off. But they're doing research to bring it back. We're hopeful it comes back. They're finding if you refrigerate the patches, it stops that crystallization. So hopefully in the future it'll come back. Bromocriptine, very old medication for Parkinson's disease. It's a mimicker just like the rest. It has a lot of side effects though, so we kind of avoid it for most patients. But since it's an old medication, that means it's cheap. So it's available. Amantidine. So Amantidine's nice because it's got two roles, and it acts between the two cells. So not only is there a cleanup committee, there's a recycling committee. So that extra dopamine between the two cells can get brought back to be repackaged and used again. And Amantidine blocks the recycling committee, so there's more medication available. And in addition, it also encourages the top cell to let more dopamine out. So you kind of get a 2-for-1 for that one, just a little bit. It is helpful in early Parkinson's, and it can help some of the dyskinesias in smoothing that out. So we give that a lot for patients with that. And since it's an older medication, it means it's a cheaper medication. So the side effects of this one. The most common things that we get phone calls about this is confusion, a little sleepiness, and also there's a type of rash called the Livedo Reticularis. And if you've never seen it, I'll show you a photo. So I think it means lacy purple rash. It's usually on the lower extremities. The rash will generally go away when you stop taking the medication. But it is something that can happen. If it does, just let us know and we'll take it off. All right, MAO inhibitors. So there's a cleanup committee within the cell too, and that's what these are. And so within the cell there's extra, or maybe it's not packaged very prettily. This will break it up, and so it could be reused again. But if you block that, that makes sure more of those little dopamine packages get to where they need to go. So we can block those too. But Selegiline, Rasagiline, otherwise known as Azilect, that some of you may be on, Zydis, Selegiline also. So sometimes the package inserts warns about taking some foods and beverages with tyramine in it. Sometimes they do, not always. Sometimes we worry about that more with a different type of MAO inhibitor, but occasionally you do find that package insert. You do have to be careful if you're taking Demerol or if you're having surgery or such. Make sure that they know. So the Selegiline was really made to be an antidepressant. And when you look at commercials and they say, if you're taking an MAO inhibitor, please let your doctor know, blah, 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 blah. It's usually a antidepressant commercial. And so naturally, that's what this medicine was initially made, but they found that Parkinson patients that took it had an improvement in their symptoms. And so that's why we give it now. And we're not really sure if it slows the progression of the disease. I do believe there was some research on Selegiline specifically, but it wasn't very clear. It can help with gait problems also, and it's useful in the early stages. Zydis Selegiline is nice because it's sublingual, and it kind of dissolves. You can just kind of take it quick without needing water. Rasagiline or Azilect is probably one of the most common ones that we give. It was under investigation to see if it was neuroproductive, and most recently it was found not to necessarily be, but helpful for Parkinson's patients, and it's convenient because it's once-a-day dosing.
What does that mean, neuroprotective?
That means, is it protective against losing more neurons, and is it protective against making the Parkinson's progressing further? They were hoping that it would kind of be like a buffer to stave off some of the further symptoms. Okay, anti-cholinergics. So that's at the very bottom, because the thinking is that there has to be a balance in your brain between dopamine and your cholinergics. So if the dopamine is low because you have Parkinson's, it only makes sense to bring the other one down too, so that they're even, and it kind of manages the symptoms. So that's this medication's role. Most commonly known as Artane, that's the brand name of it. It's helpful for tremors. Unfortunately, it's not so helpful for the other symptoms of the stiffness and the slowness. It does have a few side effects which are sometimes limiting. The confusion, hallucinations, and the dizziness seem to be the most common things that I remember patients commenting on when they're taking this medication. Also, there's benztropine. It's very similar to Artane and has very similar side effect profile. So what else in the last couple minutes? What else can I tell you about? So there's Apokyn, which is an injectable apomorphine, and it's a dopamine agonist. The mimickers, it's one of those meds. And it works within 3 to 10 minutes. It's nice. It's like a quick shot that you give yourself. Kind of like an EpiPen is what it kind of seems similar to. The benefits last about 1 hour, and so it's not something that you would take all day, giving yourself a shot. It's kind of good for that. You're stuck first thing in the morning, or your medicine just isn't kicking in well, or your dose is at home and you gotta go get it, but you need something quick to give you an hour just to get going. So that's what Apokyn is good for. It's a newer medication, which means it's more expensive. It's actually quite expensive. And this medication also has an unfortunate side effect of nausea and vomiting. So frequently, patients who like this medication will take a daily nausea medication just to prevent it, because it can be quite significant. Tasmar is another COMT, that's the garbage committee inhibiting, stopping the garbage group. It can be more beneficial in terms of it's more efficacious and stronger working because of where it works. But the problem is it causes problems with your liver. So if your doctor ever says, oh, you're on these Parkinson medications, we need to monitor your liver, this is probably the one that they're thinking of. There were a few problems in Europe with the medication, which has some people a little bit of afraid of it. And this last statement is Dr. Rodriguez personally feels that it's okay as long as someone's monitoring your liver enzymes on a regular basis. So there's Parcopa. So that's the dissolvable tablet. It's very nice. You don't need to have any water. If you're in a meeting or it's first thing in the morning and you just kind of need to get something quick and you don't want to take a shot, it's a dissolvable tablet that you can take, and it works very well. Unfortunately, it's a pricey one also. So I also want to just make a note that antidepressants in Parkinson's also is very beneficial. It helps with the energy and the mood, which seems to be a big problem with Parkinson patients. You just don't feel like doing stuff. And frequently, depression doesn't show up in Parkinson patients as it does in other people. Other people may be at home crying and just blue and kind of had that feeling, but really when you have Parkinson's and depressed, it can just be an energy problem and a feeling of that you just don't want to do too much. And so this is something that's important to consider also. And that's about it, y'all. Are there any questions, or should I wait till they let Dr. Go ahead, sure. Question?
What about timing? Let's say you just miss your bill of the working and then 4 hours to the next one.
My recommendation would be is to take it. As soon as you realize that you've missed it, take it. And then if it's seeming like it's close to the time for your next dose, just like if you know you take your medicine every 4 hours, take it every 4 hours since that missed dose. And in the morning, get yourself reset on your usual timing schedule.
What is the commercial name for Selegiline?
Commercial name for Selegiline.
One of them is Zelapar, that's one of them. Zelapar is one, and Zydis Selegiline is one orally disintegrating form, but it's usually called by its generic name most commonly. Thank you.
Sure.
I have two questions. One was I saw an article recently that talks about generic or that Levodopa maybe not being as good as the real thing for fluctuating the symptoms of you have to my mom's heart. They keep changing manufacturers all the time. My mom was struggling with Parkinson now, she's not. So that's my one question. The other question I have is Vector and cinema.
Sure. So many patients have found that the generic Sinemet is not what the regular Sinemet used to be like. And frequently, if the generic Sinemet isn't helpful for you, we do try and work around it. We may try using Stalevo, or we may try working with your insurance company, but that's very common because generic medications can have more filler or less filler than what the brand name had. So your mom is in a very familiar predicament. If it's a big issue, if you're one of our patients, definitely bring it up in clinic and we'll see what kind of options we can rearrange for you.
One thing that's interesting with generics, this comes up for a lot of different conditions besides Parkinson's, seizure medicines, blood pressure medicines, and basically the FDA has a certain guideline of how close it has to be, the generic, from one company to the next. So they may have a certain percentage of leeway. You know, it might have to be within 5%. I don't know what the actual percentages, but bioavailability means how ready that medicine is in your body for use and how it is in your bloodstream. So there's a little margin, and for most patients, I would say the vast majority, the difference between the generic and the brand is negligible. Most people will do just as well, but there are a few people who feel like they can detect a difference. And at that point, if you're able to financially tolerate the brand name, you can. If that's not financially tolerable, then you may have to change the dose of the generic medicine you're taking to achieve that benefit. But I would say in my experience, the vast majority of the people would be fine to take the generic. And then there was a question about Effexor. I don't know if you want to.
So was the question about taking?
Was your question if that's an interaction or what? No, they're very safe together, very commonly used together. Effexor is also called venlafaxine. That's the generic name. It's an antidepressant. It has some other properties. Sometimes it's used to help people with their energy levels. Sometimes it's used in people who have pain complaints, but its primary use is an antidepressant. And it's very effective and very often very well tolerated, and there's no reason it can't be taken with Sinemet. Probably have time for a few more if there are any more medication questions. Yes, ma'am. Can you answer?
You can chew the carbidopa. It will usually make it work faster. Sometimes it may cause your mouth to be orange. We don't recommend.
No, not Stalevo.
Oh, that's the
Just
Stalevo.
Sinemet.
This is the Sinemet. But you can chew it. We don't recommend it as a everyday practice. But if it's kind of like you need something quick in a hurry, you can chew it.
Yeah, actually, sometimes we tell you to chew it because it may kick in a little quicker. There's no reason you can't chew the Sinemet immediate release. Now, the Sinemet CR, the slow release Sinemet, you wouldn't want to chew because you would interrupt the way that the pill is made to be slow releasing. So regular Sinemet you can chew, not Stalevo. Don't chew Stalevo. You might get orange teeth. Yes, sir.
We were at a meeting on Wednesday at Boston Group. They just announced that this patch is doing the group.
You're absolutely right. The Rotigotine patch, which is the brand name of Neupro, it has been re-released onto the market. And it was a patch, like you heard Dr. Hardwick say, that's a dopamine agonist, so it stimulates dopamine receptors. People like it when they're sick of pills and they want something that can be just applied as a patch. It was taken off the market, not for a safety issue. It's not that it was dangerous. It was just that it wasn't delivering properly through the patch because the medicine was making little crystals. And it was something in the United States, but the Neupro made overseas didn't do that. So it was something related to the plant in the United States, and they've reformatted it. It took a long time, and it's going to be back on the market. So it will be another option.
If you take the Sinemet, you could probably switch over to patch.
Are you asking if you would be able to switch or to add?
Stop taking the pills and just go over to patch.
If you're requiring Sinemet multiple times in the day, it's unlikely that the patch will be a full substitute. It's more likely it would be part of your therapy, and maybe you could reduce your Sinemet. But it's really it's different for each individual whether the patch would be enough of a medicine for you that you won't need anything else. It is possible that it's effective in monotherapy, meaning the only thing a person is on, just like any of these medicines. For some people, they may be enough just one of them, but it's quite common to need more than one. Maybe one more?
How do you suggest experimenting with drugs? If you think something might be better for you?
I feel like I better not run for office if I'm going to comment on experimenting with drugs. But I understand your question. I'm just kidding. The question was, what do I think about experimenting with your drugs? And it's actually a smart question in a sense, because some people feel like nobody knows what their day feels like better than they do. And they may feel like, that they may have an idea of something that might be therapeutically useful. And what I recommend is, the first advice is always be super honest with your doctor. So if you've experimented, whether it's right or wrong, and you've learned something that may be useful, you definitely want to communicate with your physician because it might be helpful to making the next step. The other advice is, I really recommend just giving your doc a call and letting them know before you do it, so you can be given some advice. Sometimes an idea idea that seems really logical may actually have some risk involved. It might be dangerous. It's much better if you just say, you know, I really just want to see if I added just half a pill at 5 p.m. I keep having this down period at night. I really think I would do better with just a little half a pill. And just so we know, we say, that's fine, go ahead and try it out. And we can warn you, maybe I want to say that's fine, but you may want to be aware that might lead to this effect down the road. So sometimes we have to experiment to figure out what's going to work for each person, because nobody comes with a cookbook of what's the right recipe for them. We have to try, but it's better if you just talk it through with your doc or your physician assistant or nurse practitioner, whoever you're working with, before you implement the change. Okay, well, we'll go ahead and, thanks, Dr. Hardwick. We'll go ahead and go on to the next talk.